afternoon, friends. I'm Dr. Naresh Bhat from Aster CMI Hospital at Bangalore. At the outset, I'd like to thank the organizers, Dr. Sahu and Dr. Avinash, for inviting me to speak at this meeting. And I'm going to spend the next 20 minutes talking to you about how we hunt for early gastric cancers. These are my mentors. You have Professor Ken Yao on the right of your screen sitting down. He's what I call the father of gastric NBI. And the middle is Professor Nilay Mehta, who is again a pioneer and a good friend. And at the bottom left is a good friend at the National Cancer Hospital, Dr. Seishiro Abe, who's a recognized ESD expert in the stomach. And of course, you find my friend Amol Bapai from Pune in this picture. We all know about the alarm symptoms of gastric cancer, and this is what we teach our undergraduate students day in and day out. But we realize that all these indicate merely an advanced stage of cancer, and hence the 5-year survival of these patients is extremely dismal. We also tend to pick up patients to do endoscopy based on age and symptoms. And there's a good study which showed that age and alarm symptoms are very poor clinical indicators. In fact, about a quarter of all patients of gastric cancer are under the age of 45. And hence, we need to change our attitudes about whom to investigate with endoscopy when they have dyspeptic symptoms. So how do you get about doing this? The systematic stomach screening protocol, as advocated by the Japanese, tell us that we need to look at the stomach patiently and also document at least 22 pictures when you're looking in the antrum or the lower body or the mid-upper body, or when you retroflex, when you're looking at the fundus of the cardia, and again you look at the middle upper body and the incisura. So this kind of systematic examination will help us look at the entire stomach and avoid missing lesions. We recognize that there are potential blind areas in the stomach as indicated here, and every endeavor must be done to avoid missing lesions in this by good body movements and talking of your scope so that all these areas are well visualized. Now just look at this stomach. It looks pretty normal, as most of us, when we do endoscopy every morning, we find this. We realize that insufflation is important, and when we insufflate, we find it looking something like this, which is certainly better than the first, but we can still be missing a lot. And when you inflate further, you find that there are some kinds of suspicious lesions standing out here, which is indicated by a pale white color. And if you use other modalities of chromoendoscopy, whether digital or dye-based, you'll find that these lesions are many. There's one here right in the center that we saw in white light. There's one here and perhaps one here as well. So there are at least 3 lesions. And this I have borrowed from Professor Daisuke. And this was a patient with a maltoma of the stomach. So very simple message. Good insufflation and a good look can help you be more complete in your evaluation and miss fewer lesions. So the next issue is how to find abnormalities. Is a systematic examination enough? Do you need to insufflate? Is there more to it? Obviously more. What we need to be clear is that we need to be expecting abnormalities. And what we do is patients who are smokers or use tobacco in some form, patients who have chronic H. pylori infection, especially with extensive atrophy, patients who have upper aerodigestive cancers can have synchronous or metachronous lesions, and of course, those who have family history of cancer we need to be expecting abnormalities and must spend far more time than we spend on a routine endoscopy in evaluating them. We all have read about the Corias cascade, where he showed us that what is initially non-atrophic gastritis over a period of time becomes multifocal atrophic gastritis and then sequentially moves on to intestinal metaplasia, dysplasia, and cancer. And we realize that this occurs over a period of time of several years, and this gives us an opportunity to screen these patients for dysplasia and early cancer well before they turn into advanced cancer. And hence, one of the most important things that we should do when we do an endoscopy is to be familiar with the endoscopic features of chronic H. pylori gastropathy. And these pictures show us many things. On the top left is features of atrophy. A simple xanthoma, which we see often in the antral region, is an indicator of chronic gastropathy. You have intestinal metaplasia. Then you have these reddish lesions. You have hyperplastic polyps and a fine nodular pattern, which is called nodular gastritis. Now, why is this important? Because we know that someone who's got chronic H. pylori gastropathy has an increased risk of gastric cancer. Indeed, over 2/3, or up to 70% of all gastric cancers come from this sequential cascade of carcinogenesis of chronic H. pylori gastropathy to cancer. And hence, a bulk of cancers that we see come from this line, and hence, if you are familiar with this, it does help in being forewarned that this patient may have a small lesion that's lurking in his stomach. Looking at this closely, these are all patients with chronic H. pylori gastropathy. You have on the left, you have a kind of what is seen on white light endoscopy as these pale lesions here in the antrum. And these are all representing intestinal metaplasia. You can have these thickened folds here in the body, which sometimes are difficult to distend and because of insufflation. You can have these reddish lesions, what they call the map-like lesions, and this again represent a kind of intestinal metaplasia which is flat. And this nodular gastritis also indicates that there is chronic active H. pylori gastropathy. Coming to each of these features, we know that gastric atrophy is basically a loss of gastric glands, and they may be replaced with pseudopyloric metaplastic glands or intestinal metaplasia, or they can just have a lot of fibrosis. How do we recognize this on endoscopy? You may find a discoloration of mucosa as you see in this picture. This area is become whiter or paler. The submucosal vessels are better seen, or because of the thinning of the mucosa. And sometimes you can make out a sort of a rough, uneven surface and disappearance of the folds. In fact, this line of demarcation between the atrophy and the non-atrophic areas is a useful sign to recognize, and I'll emphasize this again. We do realize that this patient here has no atrophy, while on this frame has atrophy. This is the same picture as you saw earlier. And this patient has atrophy coming up more proximally into the body. And this has, again, fairly extensive atrophy going up all the way into the proximal body. This is called the Kimura-Takimoto scheme, where they are able to delineate and document whether the atrophy is within the antrum or is chiefly the antrum, but cancers spill over into the corpus, like you have in this patient here, or whether it's gone up way into the body or it is involving the entire stomach. We do know that a corpus dominant or a pan atrophy has a much higher risk of developing gastric cancer. And so when you use the Sydney protocol and biopsy, this is exactly what we're doing. We're trying to find out where is the atrophy. Is it limited to the distal stomach or extending very much more proximally, and therefore telling us that this patient has a much higher risk. And if you look at the odds ratio, it's almost about 8 times more higher risk of gastric cancer. The next finding is that of intestinal metaplasia, where the mucosa is replaced by intestinal glands. And this represents again a more advanced stage of atrophic gastritis. And this has a much higher risk of gastric cancer. The hazard risk is 10 to 12 times increased. And this gastric cancer is of the well-differentiated type. Now, how do we recognize this on endoscopy? When you do white light endoscopy, it may just look like slightly uneven areas here in the antrum. But if you look at it in NBI, you can make out that these uneven areas are paler, almost a kind of a little silvery kind of appearance, and these are quite easily made out when you use NBI. If you have magnification to add to it, you can make out that these tubular glands are well seen. This is actually in the body where there is the normal body pattern is changed to that of the antrum, and you have these tubular looking surface pattern. And what we see is on high definition magnification endoscopy with NBI, you're able to appreciate these kind of bluish lines on the surface of the these tubular surface pattern, and this is called the light blue crest. This light blue crest is said to be very reliable, 90% sensitive and specific for intestinal metaplasia. Unfortunately, the scopes in India, which are the Excera scopes, do not pick up this very well and are better picked up with the Lucera scopes. But yet, we do know thereby that NBI is an excellent tool to pick up intestinal metaplasia. When you have a lot of intestinal metaplasia, it can be quite difficult to pick up areas of neoplasia. And so there are some red flag techniques when you have chronic gastropathy, and one of them comes from the Fuji scopes. This is called the linked color imaging, where you don't have to have NBI, you don't have to have a great deal of magnification. But if you have white light and you have LCI with it, if you just put on the LCI, you can make out that the neoplastic area looks more orangish, while against the inflammatory area, which looks more purple at the background. So these are red flag kind of techniques which are now increasingly available. So even if you don't have magnification NBI, these are some of the other techniques that other endoscope manufacturers are able to give us. So what is the methodology or the hierarchy? The hierarchical system says first you must detect a suspicious lesion. Once you have detected a suspicious lesion on white light endoscopy, then you characterize it. And what you want to see on characterization is it neoplasia or non-neoplastic? If it's a tumor, what's the tumor border? Can you define it? And what is the tumor depth? And for this, we use NBI with magnification. Now, if you look at these 4 lesions that I have shown, which of this do you think is early gastric cancer? I'm sure most of you will recognize this very easily in the left bottom corner. But as I'll show you soon, actually all of these four have gastric cancers or a gastric malignancy. Let's see how we can get familiar with recognizing and diagnosing these lesions. The first is how to find a suspicious lesion. And this is simply by subtle changes in color, change in the texture. It can look a little, just a wee bit rough. If it's raised or depressed like this, if there is an ulcer or there is just a little restricted distensibility. So once you have a suspicious lesion, then you use magnification endoscopy with NBI. And the Japanese have coined a good term called the MESDA-G, which is a simple diagnostic algorithm which uses just three features. One, is there a demarcation line? Is there a change, an irregular vascular pattern, microvascular pattern, on an irregular microsurface pattern? And if there are one of those with a demarcation line, then it is a cancer. If there isn't, then it is perhaps a non-cancer. Now let's look at these lesions here. You see a tiny lesion that's marked out here. On routine NBI, you can make out that it's better seen. But what happens when you put magnification and NBI, you find that there's a lesion. So is there a demarcation line? Yes. Is there an abnormal microvascular or irregular microsurface pattern? No. So is it cancer or non-cancer? It is non-cancer. This indeed, actually, most of you recognize is just intestinal metaplasia. Going on to the next example here, you can see a little change in red here in this area. When you see an NBI, yes, you can appreciate that some mild depression is there. You know there's something cooking in that area. But when you put a magnification NBI, you ask yourself the same questions. Is there a demarcation line? Yes. Is there an abnormal microvascular microsurface pattern? Yes. And so this is cancer. Next example, look at this little sessile polyp, Paris 1S lesion. This is what it looks like on magnification NBI. Same three questions. Is there a demarcation line? Yes. Is there abnormal surface or microvascular pattern? No. So it is a non-cancer. This is actually a Fundy gland polyp. Look at this again, another reddish looking polyp here. If you put NBI, this is what it looks like. And when we apply those questions, we find that's again a non-cancer. And this you'll all realize is a hyperplastic polyp. Look at this again, a sessile lesion near Paris 1S. This is what it looks like on NBI. And if you zoom it, you ask yourself, is there a demarcation line? Yes, definitely. Is there an abnormal vascular pattern or surface pattern? Yes, there is. Because if you look at the vessels here, within these tubular glands, you'll find that they are definitely bigger and more irregular. So this definitely shows that there is some kind of neoplastic change, whether it's a high-grade dysplasia. This area looks more like a hyperplastic lesion. So this is an adenomatous polyp. In perhaps a hyperplastic polyp, there's a change. So this is a high-grade dysplasia or adenocarcinoma in a polypoidal lesion. This is again one of our patients that we had. You can find that there is definitely a line of demarcation. You can find these glands looking reasonably regular, but these vessels are abnormal, and this is again a high-grade dysplasia in an adenomatous polyp. Remember that not all lesions with a demarcation line are cancer. On the left, you can find a demarcation line. This is the area that is sort of has a demarcation line around it. But these microvessels and surface pattern are pretty regular. They're not the same as this, but they're regular inside. As compared to this, where there's a demarcation line, but here the surface pattern is almost lost, and these vessels are quite irregular, and this looks like an undifferentiated early gastric cancer. Now I'll just share a couple of videos. One, this is from my guru, Professor Noria Vedo. You see this small lesion here when he is retroflexed, and let's see what he finds. Look at the steps that he does, that he uses white light, freezes, then switches over to NBI, and then he tries to get closer to it, try to get en face, and then he applies a near focus. And what do you see? You see that the lesion is far bigger than we had actually thought, and the lesion extends all over here. And this is a classical example of an early gastric cancer. Again, looks like an undifferentiated type if you look at these vessels. And just by putting water, he's able to zoom it much more and get such great quality images. This next video I've had Dr. Mohan Ramchandani, who's been kind enough to share it with me. And this shows one of the newer Olympus scopes, the Easy 1500 system. And let's look at this lesion. And see, he's using a cap, and he picks up a lesion there. The little rough area there, he's not very worried about that. Then he finds some red looking thing, and let's see how he gets onto that, gets closer to it en face, puts a little water, gets a magnification with the help of that water, and there you see on NBI, beautiful demarcated lesion, nice demarcation line, irregular vessels, and the surface pattern is lost. And this again is a classical early gastric cancer. I'll share with you some of our own cases. This is one of the pictures I showed you. The clue came from a little rough looking mucosa here. And when we looked at it closely, we found that the vessels were abnormal. And when we looked at it with a magnification, we found these loose kind of corkscrew vessels. And we made a diagnosis of undifferentiated cancer. And the pathologist confirmed that they were signet ring cells on this. And so we didn't go ahead and try any resection. Straight away, this patient went for surgery and had a total gastrectomy. This is yet another patient who looks like what one would routinely call gastritis. But when we looked at it very closely, we found these very abnormal looking blood vessels. And this is called a withered tree appearance of the vessels. And this is supposed to be characteristic of maltoma. We made a diagnosis of maltoma endoscopically, took a snare biopsy because I needed a little deeper biopsies to make sure that, because maltoma sometimes can be a little deeper as well. And the histopathology and the IHC confirmed that it was indeed a maltoma. So to summarize, if you want to diagnose early gastric cancer, we need a paradigm shift in our approach. We need to suspect and expect lesions in high-risk groups, do a patient and good quality endoscopy, be familiar with the changes of atrophy and intestinal metaplasia, and interrogate all suspicious looking areas with image-enhanced endoscopy. And certainly, we'll stop seeing these kind of big lesions and see these early lesions which give us a 5-year and 10-year survival of 90%.
Early gastric cancer is defined as a tumor which has invaded mucosa and submucosa, mainly superficial submucosa, regardless of presence of lymph node metastasis. Generally, it has a good prognosis and can be cured by minimally invasive approaches. 5-year survival rate is good, being 99% with tumor limited to mucosa, and also with superficial submucosal invasion, it has a good prognosis up to 96%. Early gastric cancer is classified either by a Japanese macroscopic classification or a Paris classification, which is endoscopy based. Both are almost same with some minor differences. Mainly type 1 in Japanese classification is protruded type, while in case of Paris classification, it is protruded, either pedunculated or sessile. Type 2 is superficial, elevated, flat, superficial depressed, which is almost same in both the classification, and either it is excavated or ulcerated depending on the classification. Before planning an endoscopic submucosal dissection, it is absolutely mandatory to assess the lesion, its indication, also classify according to one of these two classification, and then plan out whether to go for EMR or ESD. In early gastric cancer, it is mainly ESD. Once the ESD is done, it has to be sent for histopathology and to see whether there was a curative resection or not. Once it is done, a surveillance endoscopy is must to see for metacutaneous multiple cancer, mainly endoscopy, and also in some cases CT and sonography. If it is not suitable for endoscopy or the lesion is non-curative resection, then patient has to go for surgery. Basically, when we are planning for endoscopic therapy, we have to rule out whether there is invasive cancer or lymph node metastasis, which is primarily done by white light endoscopy, and in present day circumstances, NBI, FISE or eye scan. In certain cases, we have to use chromoendoscopy. EUS has a limited role but definite role in subtype of cases. If we have a lesion which is mainly dysplastic, mainly non-invasive neoplasia, independent of size, can be undergone endoscopic submucosal dissection. If it is a cancer, then we have to see whether it is mucosal cancer or has a submucosal invasion. If it is mucosal cancer, then we have to see whether it is with ulcer or without ulcer. If the lesion is mucosal, differentiated type adenocarcinoma without ulceration, irrespective of size, we can do ESD. However, if there is ulcer, the ideal lesion is less than 3 cm. And if the lesion is undifferentiated type, then usually lesions more than 2 cm should not undergo ESD. And also, if it is submucosal invasion, the best submucosal invasion is superficial submucosal invasion, meaning less than 500 microns, because more than 500 microns will have a higher lymph nodal metastasis. Why we have to differentiate between these different lesions is because if the lesion is undifferentiated, has ulcer, is big in size, or has more submucosal invasion, they have a higher chance of lymph nodal invasion, lymph nodal involvement, meaning these lesions should not go endoscopic submucosal dissection. This is an early gastric cancer. First we have to mark, then we have to elevate the lesion with, usually we use gelopusine. This is a classical method where a circumferential incision is made, then the ideal plane of the dissection is reached, which is usually deep submucosal lesion, that is SM3 layer, which is the layer just above the muscle. You can see a lot of vessels and a lot of fibrosis in this lesion. Vessels are a peculiar problem of stomach. Fibrosis is because of the lesion itself, and also multiple biopsies were taken, but mainly the lesion itself. What knife we are using is a dual J knife. The lesion is dissected all around, taking care of the vessels and fibrosis. Vessels are usually coagulated either with the knife itself or coag-grasper. As you can see, the current what we use for coagulation is soft coag, effect 4, 80 watts. And for the dissection, the current we use is either endocut Q, forced coagulation, or soft coagulation. Once the entire lesion is taken care of, the base is seen for vessels, and all the visible vessels are coagulated using coag-grasper so as to prevent delayed bleeding. This is another lesion, other gastric cancer. Again, same well-differentiated carcinoma lesion is marked, injected with gelofuscin, and then ESD is performed. But here what we are doing is a different technique. This is not a classic ESD technique. This is a submucosal tunneling technique where, like POEM, we create a tunnel, but this tunnel is between the lesion and the muscle layer. So we inject, elevate the lesion, we make a semicircular incision, go beneath the lesion, make a tunnel as you can see over here. While making the tunnel, all the vessels are coagulated. Here what we are using is the knife itself. The tip of the knife is taken in, and then forced coagulation current is used to coagulate the vessel. To dissect the tissue, what we use is basically forced coagulation or endocut. You can see the tunnel is being made, and once the tunnel is made, we cut the tissue in the periphery, and the entire lesion is taken care of using submucosal tunneling technique. As you can see here, these are the last part. You can see that the lesion is taken care of en bloc. So create tunnel, then go to the periphery and cut the last remaining part. Once the tissue is taken out by endoscopic submucosal dissection, it is sent for pathological examination. What you need to see is lymphovascular invasion, neural invasion, and also submucosal invasion. As you can see in this slide, any lesion which has a submucosal invasion less than 500 micron, any size, will have a low lymph nodal metastasis. In case of higher submucosal invasion, more than 500 microns, they have a higher nodal metastasis risk, and if the lesion size is big, they have even higher lymph nodal metastasis risk. So what does that mean? That if you take an ESD but the submucosal invasion is more, especially the lesion size is big, especially if it is undifferentiated cancer with an ulcer, this patient either should go for very intense frequent monitoring surveillance or should go for surgery. Those patients who have undergone curative resection with a classical indication or expanded indication should go for surveillance in first year every 6 months and then every yearly. But in case of what we discussed, non-curative resection or undifferentiated tumor with ulcer, bigger tumor, you have to do at least 3 monthly in first year, and you have to take biopsy. After first year, it has to be done every 6 months and not every 12 monthly. Can we perform EMR for early gastric tumor? We have done it, we have failed it, and this is what most of the meta-analysis say. ESD is superior as far as en bloc resection is concerned, curative resection is concerned, and low recurrence is concerned. So ESD is preferred for early gastric cancer as far as endoscopy therapy is concerned. ESD, of course, has a more procedure time, it requires more skill. Complication wise, ESD has more perforation but similar bleeding rate. This is shown in another meta-analysis where ESD outperformed EMR as far as en bloc resection is concerned, as far as complete resection is concerned, as far as curative resection is concerned, and local recurrence rate is concerned. How about surgery? How is it compare ESD versus surgery for early gastric cancer? So if you've done for the right indication, there is actually not a big difference between surgery and endoscopy as far as 5-year survival is concerned, as far as cancer related death is concerned. Of course, adverse events are low in endoscopy route. What is important is though that the metachronous cancer rate was higher in endoscopy group. Of course, there is no scar. We can preserve the stomach with endoscopy and better quality of life. What if we have failed? We have done EMR or ESD and the cancer has come back. Should we go for surgery always? No. You can redo ESD and it has a good 5-year survival rate to the tune of 80%. Of course, surgery has 100%. So where we fail, if the lesion is big, if the lesion is in proximal stomach, then there is a higher chance of failing. So those lesions should better be taken care of by surgery and not by redo ESD. But small lesions, distal stomach, you can safely do ESD with a good outcome. To summarize my talk, I would stick by what Japanese Society guidelines in 2020 are saying, that there is a risk, very high risk of incomplete resection of recurrence with EMR. So ESD is a preferred method, endoscopic method to take care of early gastric cancers. Before going for endoscopic therapy, we have to evaluate for curative resection. We have to select those lesions where curative resection probability is high, where the lymph nodal metastasis is low. So we have to perform a good white light endoscopy, good NBI. After taking out the specimen, we have to do a good histopathology to see for the submucosal invasion, to see for the lymphovascular invasion, and decide whether this patient should go for surveillance or should go for surgery. Surveillance method is endoscopy mainly, and in selected cases CT and sonography. Endoscopy should be performed frequently if it is an incomplete resection, but can be done less frequently, initially 6 monthly and then yearly if it is a curative resection, and that is what we do. Thank you very much for your kind hearing.
So, good evening all. Shall we go ahead with the panel discussion?
Yes, please. Yes.
Sir, here in the panel discussion, the panelists are Dr. Sudhir Maharshi, Dr. Mahesh Mahadik, Dr. Tarun Bharadwaj, Dr. Deepak Madhu, and Dr. Shravan. So apart from that, Dr. Naresh Bhat sir is also there. So, sir, we can involve sir also in that. So we will go to straight away. The topic of the panel discussion is the role of pre-medication before endoscopy, upper J endoscopy especially. So the question is, are you aware? First question: are you aware that there exists pre-medication before endoscopy? Dr. Tarun, please answer.
Yeah, please. I am aware because our Eastern colleagues, Japanese and Chinese colleagues, do it routinely, and there are many literature evidence that pre-medication is available. As far as India is concerned, I am not aware if this pre-medication is used frequently or any literature is published in there. So yes, pre-medication concept is there, and we should be using it more frequently.
Yeah. So people are aware that there are medication drugs which are available before endoscopy. So could you little elaborate, Dr. Tarun, what are all the pre-medications which can be used?
Yeah, so
or even Dr. Sudhir sir can also answer.
So I am aware of 3 drugs, which is namely Samithicone is available, which is anti-flatulent, and Japanese colleagues use pronase enzyme, which is a mucolytic. India or other studies have also mentioned N-acetylcysteine, which is again a mucolytic. So based on these 3 agents, we can discuss further.
Yeah, apart from that, these are all pre-medication agents to improve the mucosal visibility. Other drugs like antiperistaltic agents, all those things are other kinds of pre-medication, but we are now focusing only to improve the pre-medication to improve the mucosal visibility. So this talk is for that only. So to do a proper inspection of the entire GI mucosa during endoscopy, we can see the pictures A and B. In that, the first ones in the A and B are having so much of the bubbles and foam, which is obscuring the vision. So after clearing, we can see small lesions which have been hidden behind it. So now, second question: what is the role of mucolytic and anti-foaming agents, Dr. Sudhir?
Thank you, Viragwan and the organizing committee for inviting me for this panel discussion.
Your voice is very low and feeble, Dr. Sudhir.
Am I audible now?
Little
Am
louder.
I audible now?
Yeah.
So there is definite role of mucolytics and anti-foaming agent before endoscopy. Mucolytics, as Tarun said, that what we used here is N-acetylcysteine, and in Japan and in Eastern world they use pronase also. What they do is they disrupt the mucosal gel layer, and anti-foaming agent Samethicone act as detergent, and it reduces the adhesive force by reducing the surface tension between the bubbles. So it will disappear the bubble. So definitely in many studies in the past also, before doing capsule endoscopy and colonoscopy, they use these agents as a cleansing agent for improving the visibility. And many studies used these agents before doing upper GI endoscopy, and they showed that they improve the mucosal visibility as well as reducing the procedure time and improve the patient comfort also. So definitely there is a role of these agents before doing endoscopic procedures.
Yeah. Definitely these mucolytics and anti-foaming agents have a role, but in India we are not utilizing it to the utmost role. We are not using it to the. We are not we are not using it to the utmost role. So next question: is mucosal visibility so important for OGDscopy, Dr. Shravan? If yes, what is the major role of it?
Yeah, Dr. Veera, thank you for giving me this opportunity as a part of Congress. Yes, mucosal visibility is very important as a part of endoscopic examination because optimal mucosal visualization without hindrance from foam and bubbles is very essential for endoscopic examination, particularly in this advanced endoscopic imaging era. Because whenever there is foam and mucus, these things will adhere to the gastric mucosa that can lead to obliteration of endoscopic examination, and we can lead to overlooking of many lesions. There was a study by Professor Udo et al. Published in 2004, where they have taken retrospectively data of 300 patients of diagnosed esophageal and gastric cancers. Out of them, at least 10% had underwent endoscopic examination within the past 1 year, but the lesion was missed. And they analyzed the data. Out of that, endoscopic error was seen in 73% of cases, whereas, this is the study, whereas 27% was the pathological error. And out of the causes for the missing of the lesion in endoscopic examination, lesion was not seen in 27%. So definitely endoscopic visualization, mucosal visibility is very, very important, and these increase the mucosal visibility.
Yeah. So these are all the evidences to show that the role of mucosal visibility plays an important role in detecting early GI cancers. So next question, is there any guidelines from our Indian society like ISG or SGI mentioning the role of pre-medication before endoscopy? Dr. Shavan? Its importance if it is there or if it is not there.
I don't know there are any guidelines from the Indian Society or SGI, and from there are some quality indicators published from the other countries. Particularly, British Society of Gastroenterology has published the quality indicators of diagnostic upper GI endoscopy in 2017, where they supported the use of these antifoaming agents for endoscopic examination, as it particularly increased mucosal visibility. After that, in 2018, Asian consensus, it was formed by the Professor Udo Rajvindra Singh, and this data was published in 2018. Here, they strongly supported the use of the simethicone N-acetylcysteine because it increased the mucosal visibility with 100% acceptance, and it was a very strong recommendation in that consensus. And recently in 2020, Japanese Gastrointestinal Endoscopic Society has published the guidelines regarding diagnosis of early gastric cancers. Here, they strongly recommend use of pre-medication for better mucosal visibility in endoscopic examination for the early detection of pre-malignant conditions.
Yeah. So the next question to Dr. Sudhir also has been answered by Dr. Shavan. Any Western and Eastern guidelines for using pre-medication before endoscopy. So next question, what are all available mucolytics and antifoaming agents? Dr. Mahesh Mahadik, sir.
Yeah, so the antifoaming agents that are available are simethicone and dimethicone, also DMPS, that is dimethyl polysiloxane is available. Yeah, and mucolytic agent which is available in Eastern countries is Prunase, and rest of the world uses N-acetylcysteine as such. So these are the agents that are being used as mucolytic and antifoaming agents.
Thank you, Dr. Mahesh. Next question to you, same. What are all different methods to administer these mucolytics and antifoaming agents? So is it a tablet form, or is it a solution to take it, or while doing endoscopy to spray? What are all the methods you know about it?
So the most commonly used methods are, first is you give a drink of these solutions, liquid in liquid, this drugs in liquid form, which is given around 30 to 20 minutes before the procedure. And the other option is to just as sometimes we do in colonoscopy, to flush the medication like simethicone during the procedure.
Yeah, very nice. So it can be flushed during endoscopic procedure, or even it can be given as a pre-medication drink before around 20 to 30 minutes. That's what Dr. Mahesh sir finally concerned. So does using pre-medication reduce the endoscopic time? Dr. Deepak?
Thanks, Veera, for asking me this question. So this specific, intuitively, you tend to think that because, forming is reduced and, mucolytics are used, better mucosal visibility leads to, decreased procedural time. But this has not been demonstrated in the randomized controlled trials. All of these randomized controlled trials, which were not powered to detect differences in time, I must confess, they all agree on one thing: it never decreases procedure time. So decreasing procedure time should never, on the other hand, be used as a metric to gauge the effectiveness of the solution, because, as you all know, increased procedural time is always better to detect pre-malignant gastrointestinal lesions. So it's not a good outcome that you should look at when you're evaluating these medications. So it may not decrease procedure time, but it definitely increases the detection of mucosal lesions and leads to improved mucosal visibility. So that's the outcome you should look for. But procedural time, it may not decrease.
So next question to Dr. Deepak: does using pre-medication improve patient comfort during the procedure? Means the comfort of finishing the procedure in a little early time also, because by flushing and removing the mucus or bubble will take, it may increase the procedure time also. So for that I had already answered. So what do you think, Dr. Deepak? So whether flushing the mucus and bubbles with water during the procedure will it affect the patient comfort and time of the procedure?
So again, intuitively we tend to think that it may improve patient comfort, but this has not been demonstrated. But that's definitely not an outcome. It definitely does not worsen patient comfort. For all we know. So as long as it improves mucosal visibility and it does not worsen patient comfort, you really needn't worry about it.
Yeah. Okay. Thank you, Dr. Deepak. Then we will go to next question. Is there a risk of aspiration by administering 100 ml of diluted simethicone and NSA-16 as a total before endoscopy? Dr. Sudhir?
We all know that the gastric emptying time for liquid content is usually 30 to 60 minutes. So hardly there is practically minimal or negligible risk of aspiration while using these agents in form of 100 ml diluted simethicone or N-acetyl-cysteine. And none of the published study also shows that any adverse event in form of aspiration of these agents. So I think safely we can use 100 ml solution, but there can be certain group of the patient where we have this risk, like the patient of diabetes, long-standing diabetes who is suffering from gastroparesis. In such group of the patient, they can have the risk. So what we can do here is we can use 5 ml solution of simethicone instead of 100 ml. And this 5 ml can be given before 30 minutes so that it will mix up with gastric juices and it will improve the visibility. This has been explained in the study by Sheng et al. Published in Journal of Gastroenterology and Hepatology 2014. Another option in front of us is by using simethicone oral disintegrating strip. And this study was done from our Odisha only, Bhubaneswar, by Dr. Ashkanta et al. Published it was actually abstracted, presented in World Congress of Gastroenterology 2019. Here they used this oral disintegrating simethicone strip 5 to 10 minutes before the endoscopy, and it has improved the visibility. And third thing which we can do in these group of the patient, we can add a prokinetic agent. So that will improve the motility and reduce the risk of aspiration. And last point which we should take care in these group of the patient, that we should never use topical pharyngeal spray, xylocaine spray along with sedation, because it will further prevent the protective reflexes and it will increase the risk of aspiration. So practically there is negligible risk, but we can take care of these points while doing endoscopy with such agents.
One more doubt, Dr. Sudhir. If we use a strip, which one is better? By using a strip for cleaning as a pre-medication of simethicone, or by giving solution? Because as far as my knowledge, by giving solution, more of solution, it will cover the maximum area of the stomach such that the visibility may be improved than giving only strip. So what is your opinion on it?
So I completely agree with you. Giving solution of 100 ml definitely will cover all the mucosa and it will give the better result. But so far there is no comparative data published. So far we can compare. That is the only one abstract which I got from the Google, that it improved the visibility. But there is no comparison data. But I think this 100 ml solution is better than this strip.
Veera, may I add something to this point?
Yeah, please add.
The other point is that you should always be aware of the contraindications or when not to do this pre-medication thing, such as gastric outlet obstruction or post-gastrectomy. When already the stomach is obstructed or the stomach is small capacity, you shouldn't be doing pre-medication or using a very less volume such as 5 ml simethicone only. So the volume needs to be considered in view of the contraindications also.
And one more point to be added at this juncture, as point raised, as we are not having Pronase in our country, but it is available in the Eastern countries, where whenever patient is having suspected GI bleed, we should not use Pronase in these circumstances as a pre-medication, because it increases the chances of bleed from these patients. So that point should also be noted.
Yeah, to summarize, the patients who are having gastroparesis, the patients who are having suspected gastroparesis, suspected gastric outlet obstruction, and patients with bleed, especially for bleed, it's Pronase, but for suspected gastroparesis and gastric outlet obstruction, better not use any pre-medication agent to improve the mucosal visibility. Right? Am I right?
Yes, correct. We agree to it.
Yeah. Thank you. We will move to the next question. Are there any adverse events that are specifically related on administering the simethicone with NSA-16? And is there any published literature? Dr. Deepak?
Thanks again, Veera, for asking me the question. So, as far as I could see, Adverse events related to simethicone and N-acetylcysteine are limited to mostly allergic reactions, but those are very infrequent. And these are drugs you're really already familiar with, using it for other indications. You're already familiar with, so that these drugs are safe. But one thing I would like to add is, there are a couple of papers that are coming. There was one article that was published in GI endoscopy, 2 articles in GI endoscopy, one in endoscopy, and one in an infectious diseases journal, all concerned about endoscope reprocessing being interfered with by simethicone, which forms crystals in scope channels. And there was a Canadian position paper that had advised against using flushing, intraprocedural flushing. Yeah. But still, we are really not sure what the practice in these centers were with regard to oral preparations. But flushing is definitely, because it can get precipitated in the channel. Flushing is probably not, you should really be, until we have more studies. But oral preparations, we still don't have much to, much data to really worry about. I think so.
Because when we use this diluted solution of simethicone and N-acetylcysteine, some particles of simethicone may stick inside the channel, water flushing channel, and it may be a focus for bacterial infections, even if we disinfect properly. That is the reason why it is also mentioned in the paper.
Excuse me.
One more thing.
Hello, the time is now over.
Yeah, almost
all the panelists now. Time is over now. Please bear with us, and now I have to go to another session. Thanks to every member of this panelist and the speakers, Professor Naresh sir, and all of you. So many thanks. Thanks a lot. Huh?
Thank you. Okay.
Thank you.
Say goodbye. Thank you.
Thank you very much.